Welcome to the Research Works podcast. My name is Dr. Dana Poole and I get the privilege of bringing to you a very special series this week. I am here in Slovenia at the European Academy of Childhood Disability, interviewing the researchers and presenters about their work. This is very exciting and I can't wait for you to delve into this whole research conference series. We hope you enjoy the series. Welcome back, everyone. We now have our second guest on the ResearchWorks podcast, special edition EACD. Old friend of mine, Dr. Caroline Alexander. Welcome.
Hello, Dr. Poole.
That does sound a little bit strange, doesn't it? Now, Caroline just came from your presentation, oral communication. Yeah. How was that?
It was really good. It was exciting.
Yep.
It was,
good.
I think, the first kind of oral communications of the conference. So it was fun to kick it off. And
what
now,
a nice way to start. And you got the big hall as well.
We got the big hall. I was quite intimidated when I realised we're in the big hall. That was definitely the biggest room I've spoken in.
Yeah, I would have to say that was a lovely hall to do your first presentation in.
Yeah.
But this is going to be great. I'm loving that we get to start talking about this work. I know that you're the lead postdoc for a lot of the work that we're about to talk about. Yes. So that's fabulous. But let's make sure everyone knows where you're from. So Curtin University in Western Australia, honorary at Telethon Kids Institute, based at the Perth Children's Hospital. Anything else to add there? It feels like it's a long list.
That covers it. It does. It feels like it's a long list. We've got a really amazing integrated collaborative team. So
I guess that just describes what research looks like these days. I think to make the kind of impact that you want to have, it's not done in silos.
It's absolutely not. And that kind of clinical integration is just key to making sure it's demand-driven, but also we've got that knowledge translation back.
Yes, that's so great. That's integrated into our models now. Look, when we first met, we were both budding PhD students.
We were.
Very much looking at gait analysis and movement. And so you have found your way to this area.
Yeah.
Tell everyone a bit about where you found yourself. What's your big postdoc at the moment?
I know, because it seems like it's quite a contrast from clinical gait, which, as you say, I did my PhD in. And this is looking at movement analysis in infants for early detection and paving the way for early intervention. So,
I love that.
Yeah.
It's so thematic at the moment because we know more and more early intervention can only be early if you can detect it early.
Exactly. Yeah. So if we can't pick things up early, and that's what the Early Moves project, which I'm a research fellow postdoc on, is looking at how we can use early movement assessments in infants to pick up cognitive impairment at a population level. So it's a really exciting
that's the
project.
part that's really unique, isn't it? So we're not just talking about the triangulation of general movements, MRI. We're not just talking about that. We're now talking about cognitive impairment. Right? Can you talk a bit more about that? Because I think that's really unique, isn't it?
Yeah, so I mean, general movement assessments, we know there's lots of evidence for it for picking up cerebral palsy, and particularly in high-risk infants.
Sure.
But, as we go along, there's more emerging evidence in those high-risk groups that it can help detect other neurodevelopmental disorders, because they really think of it as a window into the developing brain.
Yeah,
so how that brain's going and what we can see from that. And so we're rolling that out now to that population level of going, okay, if we can pick things up at a population level so you don't have to have those known risk factors to get that screening, what can we find out and what support can we offer?
That's so cool. That's really great. So there's a lot of pieces to this puzzle, obviously. Yeah. So you presented one of those pieces of the puzzle. Well, let's talk about that first, because I do want to talk about your poster. So there's a multifaceted thing here. So let's talk first about what you presented today. So the title of this presentation was Interrater, Reproducibility of General Movements Assessments and Motor Optimality Scores in a Large Populated-Based Cohort.
And that's a very wordy title.
Oh my gosh, that was really wordy. Normally I'd give this to Ash, but... No,
I got good wordy titles. You got to get it all in there.
That was a good one. Okay, so talk me through about why you had to conduct this part of the study.
Yeah, so it's really obviously the general movement assessment. We do use it clinically. But often it's done, in big teams. And so the clinicians will, sometimes get together and discuss those tricky cases. But if we're thinking about a population-based rollout, thinking about things like artificial intelligence and machine learning to automate or semi-automate the process, it's really important we understand those test properties and how reproducibility reproducible it is. That reliability, the agreement, so that we can kind of inform those future future projects.
And that's such a good point, even talking about Interrater reliability, because I guess there's quite a lot of risks if there isn't good reliability. I mean, there's a lot here, but how about you tell everyone about what some of those risks might be in the particular population we're talking about here?
Yeah, so it's really, if you have low Interrater reliability or low agreement on these things, and you are just single scoring the study, the videos, there is the risk that you'll miss someone.
Yeah, yep. So it's a big deal.
And when you're going, often when it's used clinically, it's used in integration with many other assessments, and there's that whole clinical picture that you can get. But when you're talking population-based screening, you're relying on that 3-minute video.
Yep.
And that, as if you're doing single scoring, you're relying on that video being scored correctly. So it is really important that we have high reproducibility.
Yeah, that's so good. So tell me what happens in that 3 minutes. What does that look like from an assessment perspective? What are they looking for? Looking at. So there are 2 different assessment time points we do. My talk I've been doing today, and my poster is all on the fidgety age. So that's kind of the 12 weeks to 15 weeks post-term. And they're looking primarily for fidgety movements. So those are those small, really twitchy movements. Twitchy is a very funny word, but those little tiny amplitude variable movements in all the joints. And then they also do a more detailed scoring, looking at different movement patterns and postural patterns and things like that. And so for those who are not so familiar with the terms for general movements and fidgety, are we wanting to see fidgety movements? Are we not wanting to see fidgety movements?
Yeah, it's funny because you think you aren't wanting to see these little twitches, but you are.
Yeah.
We're at normal fidgety movements. The baby is showing those beautiful little, they almost shimmer.
Sure.
Shimmer with movements, even when they're kind of the underlying, they're not moving big amplitude movements, but they're still kind of having those little movements. And so if we don't see those, that's the biggest predictor of cerebral palsy risk.
Yeah, sure. And when are we filming? So I gather that when you're filming these moments, you're picking particular moments to be able to score it on. Was that something that had to be really specific as well? Yeah,
so we get in our project and a lot of research now, the families record the video themselves.
Yep.
We've got a smartphone app called Baby Moves.
Yep.
And so they record the video and upload it direct to the research database.
Great.
From the comfort of their own home. So we're getting a 3-minute video.
Yep.
And then the assessors are looking throughout that period, but they are making sure, if the baby's distressed or is crying, we can't score that because that will change the movement. So they're looking for those nice, calm, happy baby moments.
Okay. So when the child is calm and happy, they're lying on their back, I presume, for these assessments.
Lying on their back.
You should be able to see these fidgety movements.
Yeah.
Yep. Okay.
You do need to do some advanced training. So not everyone can just look at a baby and be able to detect them.
Yep.
So there are courses run by the General Movement Trust that certify clinicians to be able to conduct the analysis.
Yeah, great. Okay.
Yeah.
So that was a good explanation. What did you find?
What did we find?
Yeah.
We found we've got really, really good reproducibility.
Wow.
So almost they kind of use the term almost perfect, which sounds quite loaded, but that's a proper statistical interpretation.
That's great.
Really excellent reliability. And what was really exciting is we also looked at the agreement as well. So often people kind of report on the reliability, which is the difference or how well the assessors can distinguish between participants.
Yes.
But we looked at actually that measurement error and the agreement, and we found it was really, really, really good.
Oh, that's fabulous.
Really happy. So Early Moves has been, on the basis of that, has able to move to a single scoring protocol.
Wonderful.
Which is really exciting.
From a resource perspective, that means you can roll it out. Yeah. So a really important piece of the puzzle. So I guess what's your main take home and main sort of top tip for clinicians or people looking at general movements?
Yeah, so I think in a well-supported team, and I think that's something that is really important to note, is our team are all experienced assessors. There's a team of 6 of them. They meet regularly. They're well-supported. They do regular professional development and training. But in a well-supported team, it's a really reliable and reproducible assessment. I can't even get my tongue around that word.
They're big words. You put them in there. But that's a really good point, though, right? So that you can't just... Sometimes there are skills that we need some special skills for, and in this particular area, because it means so much, you do need to have that. But if you have that training in a team,
that support,
it is reproducible.
It's definitely reproducible.
Yeah, reproducible. That was wonderful. Let's quickly jump over to your poster. So now your poster is called Age-Appropriate Movement Repertoire and a Large Population-Based Cohort. Still saying, it's quite hard to say, but tell us a little bit about why you decided to put a poster up on this topic.
Yeah, so I think even though I say population-based cohorts so many times in my talk, it's because it's what's quite unique about the early move study is it's always been, or not always, but it's, most of the research is in high-risk groups.
Yeah.
So, we've got extremely preterm, extremely low birth weight, all the kids in the neonatal intensive care units.
Yeah.
Those are the main cohort that's assessed. So this is quite unique in the population level.
Yeah.
And one of the domains that's assessed in the motor optimality score of the general movement assessment, that's that more detailed one, is age-adequate movement repertoire.
Okay.
And we were really interested in we've got a population cohort. What is the age? What's our rates of age-adequate movement repertoire?
Okay.
And we found they were a lot lower than we expected.
Okay, so what does that mean?
It's interesting because there's not a lot of evidence on what age-adequate movement repertoire means developmentally. So for the long term, what it's indicative of in terms of development. We know that the total optimality score can give us information about the severity of movement disorders.
Okay.
And it may reveal other neurodevelopmental disorders outside of cerebral palsy. A low score might be indicative of other things. But adequate movement repertoire itself as a domain score, we don't know much about what that means in the long term.
So is it currently used in practice?
The fidgety movements, definitely.
Yes.
Motor optimality score is being used more and more because, as I say, it can be indicative of severity of disability.
Yep.
But we don't go down to the domain level in practice.
I see.
In clinical practice, we look at the total score and we look at the presence or absence of fidgety movements.
Yep.
But we don't look at the domain. And I think that's probably a good way to go. And as we move forward, we'll understand more and more about what those domains mean.
Right. So where do you think it's headed from here? Given what you found, where do you think it's headed? Like, what's the next lot of work that needs to happen now?
I think there's two pieces that will come out of the age-adequate movement repertoire. One is what does this mean for long-term development? So within the early moves program, so all the infants that were in that cohort that we looked at will be getting a Bailey developmental assessment when they turn 2. So we'll be able to start to link to that. So maybe that top score, that optimal normal present age-adequate movement repertoire, it may be indicative of high-functioning motor domains or something at age 2. So we need to look at that, but also look at, how we're defining what age-adequate movement repertoire is and what are the different movement patterns that we expect at each age and is that actually realistic in a 3-minute video? Because it's a very small window of time we look at.
And I guess that's important for us to be able to know because it sounds like this is giving us an indication of where to and it gives us an ability to maybe plan services the way that it might need to be or direct them in a certain direction so we can do early intervention. Is that where it's headed? Is that why we need to do this?
Yeah, definitely. So I think being able to, do that early screening, look at the different domains and what it means and understand what that is potentially prognostic of.
Yeah.
That's the wrong term. But you know what I mean.
I know what you mean.
where that's taking us and be able to tailor those interventions early.
And so when do you think the early move study will start to be able to produce all these?
Question.
Yeah, it's a big question, isn't it?
Big question, yeah. So early moves is wrapping up recruitment at the end of this year.
Okay.
So we're looking at end of 2025, early 2026 to finish our developmental assessments.
Fabulous.
So in a few years' time,
we'll chat to you again then. Well, I love that you're starting to really talk about this study and all the little parts that really do form the big story, right?
Yeah.
There's a lot to it.
There's a lot to it, and it's really great to be able to actually start to delve into some of those component pieces and go, we've got this wealth of data.
Yep.
What else good can we do with it?
Yep.
And I think this is part of that.
Okay, so one main point as a summary of the work that you have presented today and you want people to remember, what would that be?
The main point would be in a really well-supported team with experienced assessors, it's a really reproducible assessment and the best way to do it is use that total optimality score
Yep.
and the fidgety movements. Domain level's interesting, but we're not there yet.
Okay. Brilliant summary. Well, thank you so much for taking the time to sit down and have a chat about this, and congratulations on presenting your work here today.
Thank you.
All right, everyone. So if you want more information about this particular topic, head to our website, researchworks.net, and stay tuned for more episodes. Thanks for listening. Talk soon. Bye.